I can read the mind.
Good morning and welcome to our monthly webcast. This is session number 21. I am Samir Mehta, your moderator, and we'll take you through another very exciting complex coronary case. This morning is also special. We have continued to climb rapidly on the social network mechanisms. Please continue following us on Facebook and tweet us. This morning we have a very interesting case for you. It's a radial intervention, and we hope to show you the entire case from the beginning, because I think it is very important to demonstrate how a patient is set up as well as the access and everything else which follows. So without any further delay, let me take you to the cardiac cath lab. And Anu, good morning. Are you there?
Yeah, good morning everybody.
Before you start, I have a very nice message for you specifically from Dr. Ashfaq Patel from Doha, Qatar, who feels that you are one of the most talented interventional cardiologists in the world.
Absolutely, I agree with that, yes.
I thank Dr. Patel also for his various other comments, and of course we'll try to benefit from some of those. Please keep following us both on Facebook and Twitter. And Samin, take us through what you have in mind for today.
Well, actually, as you know, that America is usually a little late in catching up on various techniques, technology, devices. Part of that is our regulatory, but more important is the mindset, and particularly the radial artery intervention, PRI in brief we call, is really, while has become the center stage in many of the countries out of US, whether you take it Europe, India, and anywhere, that in US we were lagging behind. So we felt that, and now of course everybody is interested in radial. So our focus will be the next few series of our monthly webcast concentrate on the radial. So today will be more on a technical aspects, preparation of the patients, and a little more theory we'll be talking in the future. So that we felt at Mount Sinai we also took the same the stand that let's get on to this radial bandwagon and try to do more cases radially. We used to do about 6 to 7% last year. Now our number is just double in the mid-teens, the radial intervention. And Anu and actually my other associate Michael Kim both have taken initiative onto the radial. More important, Anu has taken a lead in terms of how to set up so that the staff, patients, everybody is happy once the radial procedure is done, and not like something that you have to take it out from the box and everybody giving a resistance. So the Anu, the goal will be here. First, she will demonstrate that on some, actually on a volunteer, and then we do the case. Anu, you take it now.
Yeah, good morning. We're just going to show you how to start preparation on a patient, and we have a volunteer, Mr. M, who's going to walk into the room, and he'll be lying on the table. And this is the radial board, and if you see Kevin, our one of the tech, this is the homemade radial board. It's just a plastic board that has been cut out, which is almost 3 feet wide, and length we have about 5 feet length. This is the way we did it, so that patient will be lying, this much of the portion of the board will be under the patient, and here you have the smooth curvature, so that this will be on the operator side will be easier when the board is placed. So we take this board and it is placed under the patient right here, and once that is done, once the patient is lying down, it's already, this is just some sheets which has been placed here, and we will do the Allen's test.
And as you know that the Allen test actually is although I would say people still talk is the absolute contraindication that your Allen test is negative, but truly many people believe that it doesn't matter because the ulnar circulation is good enough and you should not even waste time. Many people believe that way, but we still continue the tradition that do the Allen test positive.
You have to show that the pulse oximeter, or you actually show it on the,
yeah.
Can you see that?
Right.
So I'm compressing both the radial and the ulnar, and now I'm releasing the ulnar. If the radial is occluded, that means he has a good collateral circulation, even if there is a occlusion of the radial, which could happen after the first procedure anywhere up to 10% of the time. And once that is done, Pablo, we have two things. This is the other small radial board, which is done by the St. Jude's, and this is the angiocath, which comes from the Terumo. So here you have already placed, this is just the sheath. The most important thing here by doing this, putting this board and putting this around the arm, what happens is here is prepare it, that you hyperextend. Hyperextension is the key. So the radial artery is well exposed, and depending on the height of the operator, you may have to bring the table up, because I need the table way up. And how you are going to prep the patient with the blue?
Anu, have you
Yes,
also
quick.
prepped? Have you prepped the left wrist also?
Not in this case.
Yeah, but that's a very good point. That question is, if you're going totally radial, you do a both wrist, or many people, I would say that particularly that in United States where there is a less resistance in terms of going to the femoral, it is completely fine that if you need to, that you make a radial as well as one side femoral. Like this same drape, we are not changing the drape. The same drape, instead of going to the both femoral artery, it goes to the right radial and right femoral. So no need to prep the groin. The key is it becomes very handy for many of the women that you don't need to they don't have to undress, and even of course from infection point of view you need to be careful, but otherwise that require very little preparation from the patient point of view, because otherwise we have to shave and all changing the gown and so, which can all be eliminated by the radial. But you are good point. Many people will prepare both radial, but what we do at Sinai is the prepare, if need to be, when you think there is a chances we'll fail, and I'll discuss what cases are where you could fail, that will prepare the right femoral artery and the radial.
Well, that's exactly what I do for the STEMI interventions. Both radials and the right femoral are just prepped and shaved, and you proceed with the right radial as a first start.
So the one important, I think, practical point from this particular board, because now you have the working space, and with open your, how you prepare your A-line. When you have your A-line connection and you're finished your access. So when you're getting the access, one important point you need to do is what they normally say in the past days, to say go just medial to the styloid process, but now what you're teaching is that you should go little higher above the styloid process, because at the level of the styloid process you could have a lot of other small branches. So you give 1 to 2 cc with the small needle.
Yeah.
Now we already obtained the access. With the small needle, which is the blue needle.
25 gauge.
That's the
25 gauge. 25 gauge.
Got it.
And just underneath at the level of the skin. And after that, you have to make a nick, because this is where the controversial point is. Many people say don't do the nick, and some people say do the nick. Once you do the nick, through the nick you will be able to get the access very easy, and then the best thing would be using the angiocath. The reason for this is most important, that there will be less spasm. So the same Seldinger technique, go through and through, and when you go through and through, you'll see little blood. Take this out, and then you start bringing your angiocath backwards. When you start seeing the flow, just go forward with the wire. And when you're going in the same, since this is glide coated sheath, you don't need to dilate. You can just go in and then flush and give some vasodilators.
And I think that's the important point, that whether you should use just the needle or you use the angiocath, I think it's still controversial. I know out of US everybody uses angiocath, but in United States, even very expert or very busy the radialist, I call them, they still go with the fine needle, which is fine. The believers, there is no randomized trial to answer that question, but the believers of this posterior wall puncture Seldinger modified technique are believer that it causes less spasm. But I know in United States, still majority of them go with the small micro, the 25 the gauge needle, and then you advance the wire. But clearly this field It just has to be that you develop your own experience.
Well,
Yes.
I think the real important difference there is to go through and through rather than just the antegrade stick. Anu, what are you doing to provide yourself a little extra barrier for the increased radiation?
Yeah, I mean one other point we always worry about that could it be more radiation to the operator, since now we are slightly closer to the the camera because of the where the hand is going to be placed. You got to make sure your shield is right in front of you, and other thing is you can use this extension tubing. Once you use the extension tubing, you have your guide or your catheter in there, you connect it here, and then you connect this to your you're able to then do your procedure.
Just gives you an extra 2
time.
feet to
Yeah.
be away from the...
And since you have your workplace here, you can stand away just like your femoral. Your femoral axis is here, your radial axis is here. Again, you are probably almost a foot away from the camera, and you'll be able to do your procedure right where the patient's knee is. So that way I think you can avoid your radiation exposure also.
Excellent.
Now, if for reasons where you have to go left radial, most important, if they have bypass, what you have to do is in this particular situation, you have to go to the left side, get the access, give me your hand. And once you do that, you bring your hand across, place it on the belly or the thigh of the patient, and you start working at this level.
Perfect.
Very good.
Anu, excellent demonstration. I know you are doing more and more radials. Are the patients happier getting this procedure as opposed to the femoral route?
Your patients are happier since ambulation time is the most important thing for this. That's one, and most other thing also is I think we don't have to worry about the closure device, type of closure device, and they are.
Well, I also know that Mount Sinai is aggressively moving towards same-day PTCA, so that would be helping also, no?
Well, that's a very good point. The key is coming back to the point that from patient point of view, I can tell you that I have a mixed reaction or demand from the patients. Many patients are coming because the radial is so much talked in the general media and the literature and the newspapers and so that they are asking for radial. Now, having said that, the patients who have had both radial and femoral, I would, if you take my vote, it's a half and half, and tell the patient third time, which one would you go? Actually, little more than half will say, go by femoral. I think it's part of the little bit of that initial pain which they feel, while the femoral is totally painless. Coming back to the point, what the same day discharge, which our paper of the JACC intervention last July, included that 96% of cases were done femorally, 96.4 actually, to be precise, that they were done femorally. But if you do a closure device, to me, at least the ambulation time is significantly minimized, so that even if you do a case at 7 p.m., by the femoral route, patient still can go by 11 o'clock in the night. But yes, the study has shown that transradial intervention decreases the length of stay and allows you to send more patients same day home.
Well, hopefully in 2 weeks' time we'll get more information from so many more new trials being presented.
Yes. So now
Okay,
if
we
that is
move on
okay,
to
that we go to our side. Now we start our actual case of today. We'll present it, and while Anu will be getting ready with the diagnostic catheterization, I'll go over about 10 minutes, because we have decided that the most important time should be given for the case preparation and case performance rather than the slide. So I'll always keep it now, the presentation, just under 10 minutes. Anu? If any other question, we can answer meanwhile.
Well, Samin, this has been a very nice demonstration. Please continue sending us any of the feedback, and please follow us both on Twitter and Facebook. I continue to keep getting messages from both, and I am actively tweeting at this moment.
Good.
Samin, so now you've switched back to the other room?
Yes. So we are switched back to, and we can start our slides.
And we need to thank Mr. M.
Yeah, Mr. M, thank you.
Yes. Very good. Now, our today's the case number 7 of the Heart.org series. It's a 68-year-old male which presented basically with a 2-8 in February 8th with class 2 crescendo angina and has a positive stress test for multi-vessel disease. And at that time, he was found to have 3 vessels. Circumflex seems to be culprit with normal LV function and had PCI and continues to have class 2 angina. He has multiple risk factors, including peripheral vascular disease, and has a PTA, so that's an ideal case for radial intervention. That's where the question always comes. The radial intervention, patient with a PVD makes it ideal, except also the patient with a high BMI, and so on and so forth. Therefore, this particular case has even PTA, has a PCI in the past of the RCA and circumflex a long time ago, and now presented, as I mentioned, and is on a good medical therapy. From angiographic point of view, we'll have a more chance to see it. 3-vessel disease with an OK left main, but significant calcific LAD diagonal bifurcation. Had 2 lesions in the circ and also 2 to 3 lesions in the RCA. At that time, syntax score was 22. Because of the ischemia, were more in the severe in the infraposterior segment, infrolateral segment, had a PCI of the circumflex and OM, and now here still continues to have angina. We switched him to prasugrel, and we have tested him for verify assay now, and is 77% inhibited, which has been the normal story. Patients on prasugrel, even on 5 milligram maintenance dose, have very high inhibition of platelet aggregation. So today our plan is radial PCI and performing the PCI of the LAD diagonal bifurcation because of calcification, likely rotablation, and if necessary, may need the RC also we can do. Today the syntax score is 17. Now, if we go through our appropriateness criteria, every case we put a case at Mount Sinai has to fit into this category. That eye, if you do an intervention which is a red eye, that has to be a reason for it, clearly explained, so that we have the whole setup with the fellows, nurses, and nurse practitioners, that we are already ready which category this patient will fit in. This patient has class 2 angina, 3-vessel disease, and high-risk non-invasive test, so that basically it's appropriate by our criteria point of view. Basically, the points involving this case being a transradial intervention, bifurcation lesion, plaque modification, calcific lesion, but we'll just concentrate only on the transradial intervention because we have done enough discussion about bifurcation and plaque modification in our previous presentations. Now, the question basically is transfemoral. Has been there for longest time, facilitated use of larger catheters, everybody very happy, use a closure device, seems to be completely fine, you could even go home same day, and the disadvantages are that prolonged bed rest, there is still some back pain, bleeding, vascular complications, and of course vascular closure device we say they are okay, but they do have still issues in terms of bleeding, infection, embolization, small group, and the recent study which showed the comparing the vascular closure versus no vascular closure device, that basically there is no manual closure, and also similar data from Cleveland Clinic and other centers and Brigham, that there is not true statement that vascular closure device decrease vascular complication. They do decrease the time to ambulation for sure, but overall no difference. And therefore, why radial intervention then? Because we are so good with the femoral. But very important is advantage, which we have briefly spoken, the decreased incidence of major access complication, access-related bleeding, or you can remove the sheath right away, superficial location, you can press it well, decrease time to ambulation, decrease post-procedural cost, and improve patient mobility. Now, this is the major study, I would say, that in US, if I had to point to one article which really brought this to the center stage of discussion, was this by Sunil Rao from ACC NCDR PCI registry, where they looked into is over 59,000 patients, 593,000 patients, and compared radial access versus femoral, and basically found that while access procedural success was slightly in favor of transradial, but very important, vascular complication and bleeding complication were significantly lower with a transradial, and irrespective you are young age, old age, male, female, stable patient, STEMI patients or non-STEMI patients. So this is the landmark was in 2008, and clearly you can see How many patients were being done by radially in United States at that time? 1.3%. So that while we were very back behind, but we needed to bring it to the central stage, and I give credit to Rav to make this to really increase the awareness. Since then, there have been a lot of other publications which actually have shown that even radial may decrease mortality at follow-up. And you can see the radial access was associated with, from British Columbia registry, mortal, that associated with in large number of patients, 38,000 patients, that has an odd ratio of 0.83 with a p-value of 0.001 in decreasing the mortality. Similar, the data from Canada by Jolly, which evaluated 23 randomized trial with 7,000 patients, randomized to femoral or radial, and basically found the few important observations. One is access site crossover, that yes, if you go radial, the failure will be higher to get access to the devices and so, and therefore you may go to the femoral. So clearly, access failure is much higher with the radial compared to femoral. This is the meta-analysis in the randomized trial. Although in the individual data, this may not be true, but this is what the literature is. Second, major bleeding. Thumbs up, basically for the radial. As you can see, the odd ratio is 0.27. That you decrease by 73% chance of bleeding by using radial, and major bleeding and of course minor. Now also death MI and stroke, that you decrease it with the odd ratio of 0.71, 29% decrease in death MI and stroke, with the p-value for the death alone was 0.12. And I think this is all related to a lower bleeding. So lower bleeding translate into a lower death MI and perhaps stroke because of exchange catheters in favor of radial. And also radial did that patients went home early. It's about 6 hours early discharge in the radial patients, as you mentioned earlier. Then also the question comes that what about our in the acute coronary setting, which is the radial PCI sub-study of the acuity trial. You can see the heparin, bivalodin and GP2B3A inhibitor, that basically radial access and femoral access, the bleeding point of view. Even in the bivalodin group, by using the radial, you'll have a lower bleeding compared to the femoral access. Now, the economics, clearly by shorter length of stay, the decreased vascular complication, you can get the patient out early and will be financially beneficial to the institution. The question then comes, it looks good, then why, what is the disadvantage? Well, disadvantages are catheter manipulation needed for coronary cannulation. Judkins catheters go in. We tell the fellows, don't manipulate catheter because they will automatically go into the JR and JL. JL definitely, JR need a little bit of twist, but they will go automatically. But radial will require manipulation, and sometimes you have to push it hard, so that if you are not careful, create a dissection of the ostia of the vessels, whether it's a left main or RCA. So clearly catheter manipulation is the issue. Therefore, there is a whole the device industry making special catheters which will fit in and goes into the vessel without much manipulation. And of course, the vascular anomalies and very tortuous vessels will give the trouble. And then, of course, if you want to go to a 7 French for the 2 stents or the bigger rota bar, you may not be suitable for every patient. But those who have used it tells me that putting a 7 French catheter, if you put a 6 French, that 7 French will go in 90+% of cases. Then issue comes 2 important, learning curve and higher radiation exposure. And I'll come back to both of them, very important. The learning curve basically is that you need to just get your strategy correct. As Anu pointed out, the access, radial artery spasm, and traversing the subclavian, there are issues with the backup and loop. If you have your technique correct, and again, with the angiocath, maybe cause a less spasm, and giving a combination of various drugs with the cocktail of verapamil, lidocaine, and heparin and nitroglycerin has reduced the spasm. And the second is the loop. Many times we try to advance the wire, but there is a loop. So you need to be careful, and you can just negotiate as long as you have a little angiogram and take care of the loop, and then it will be fine. Second issue comes is that what is the learning curve? Of course, there is a issue with whether 80 or 100 patients. We actually now recommendation is 100 patients, but I have one publication about this to answer that question. The cutoff was about 80 patients, that your access failure, your sheath insertion time, procedure time significantly went down once the experience exceeded 80 patients. So that clearly, once you decided, you need to do more to be perfect. Then issue comes the radiation exposure. Is that true? There are some hearsay, but only thing I could find in the literature was for the radiation for the diagnostic cath and PCI of the RCA and left system clearly seems to be that higher radiation with the radial versus femoral. But again, the point which Anu made, that keep another 18 inches long your connection tube, so you are away from the patient, so you are standing exactly where you will be the femoral, will decrease the radiation exposure. Now, contraindication we talked about, abnormal Allen test for some, and of course some people say, well, you cannot do right heart catheterization. I can tell you there is a whole, the publications and impetus now is for doing a right heart through the antecubital vein, that you can use a 5 French swan, so that you don't need to puncture, no need to preparation of the groin, and use the antecubital vein and use the for the right heart catheterization. Radial artery occlusion we have spoken, occurs in 10%, usually not an issue, and there is a whole technique about patent hemostasis, that not when we usually leave the band, which will show in the end, leave for 2 hours, give rise to about 10 to 12% occlusion. But if you have patent hemostasis, they loosen the pressure on the radial artery while compressing the ulnar artery, return of the that is associated with the lower occlusion of the radial at follow-up. Having said that, I think we're just about ready now, and we start this particular case and trying to perform the complex intervention in this patient.
We already have the access obtained on the right radial.
Anu, what size sheet do you have?
This is a 6 French sheet. We haven't done angiogram because we want to show everything right from the beginning. So we have a diagnostic catheter. If you can see, there are 2 kind of catheters available. One is, can you show there? The Jackie, and the other one is the Tiger. Based on the operator's preference, you can try any one of those.
Before that, what kind of anti-spasm cocktail have you used?
Yeah, I'm just going to start with that. So as soon as we have the sheath inserted, what you can do is place a large tegaderm across the sheath, so that now it has stabilized. Few people may even suture the sheath so that it does not move. In complex situation, when we are focusing on how the engaging the guide and the catheter, many times this sheath often comes out. So you need to stabilize the sheath. Once that is done, make sure your pressure is good. Based on the blood pressure, then you use the verapamil, which you take a 2.5 milligram, you make it 10 cc, and anywhere between 250 to 500, and then you give also the nitroglycerin anywhere between 300 to 500 micrograms, again based on the blood pressure. Then anticoagulation.
Actually, coming back to that cocktail infusion, in the literature I came across giving a lidocaine also, at the 2 ml of the 1% lidocaine diluted. We don't give it, and maybe we can get some response from the audience that what is the practice. But other 3 are, people actually give up to 5 milligram of verapamil.
Yeah, well, same, it depends on the blood pressure and the heart rate, but very important, I think, when we are getting the access, patient has to be well sedated. If patient is not well sedated, likely the radial artery can go into spasm, because the key in the radial artery is getting the access first time. If you are not able to get the access first time, likely everything may go into the spasm. And now we have once you have the sheath is in, other question also is anticoagulation. If we are planning just diagnostic, we can give based on the body weight anywhere between 300 to 3,000 to 5,000 cc of heparin. And right now we have the Tiger catheter, which is we are going to use for the diagnostic. And what is the kind of wire that we are going to use? Again, how the camera is going to be placed, you got to move this laterally so that you can then image the radial artery as you are going up. So we insert the catheter,
because that is where with the loop issue will come. In some of these cases, that you have a trouble, particularly at this level, and there is a loop, and then will be a issue.
This is a Terumo wire.
I mean, also I think the advent of the hydrophilic wires and the sheets has also made things considerably easier.
Yes.
But you still have to be very careful with the another.
Exactly, in the subclavian region.
Yeah, subclavian you will have loop here and may go into the carotid vertebrals. You got to be very careful. So keep advancing.
The camera.
Yeah.
Okay.
RM.
Okay. So the first thing is good thing about this catheter, you can do your LV, the right angiogram and the left.
Well, I can already see a lot of calcification.
Yeah, few stents and few calcium, lot of calcium, particularly in that LAD area.
So, I mean, you mentioned very nicely in the beginning of the case how the United States in some matters has lagged behind. I remember watching Xience V DES do complex rotablations through the radial route as early as 15 years ago.
Yeah.
And people who have followed Tejas Patel in India are just amazed at the simplicity.
And that is a very good point, because the latest data are that in Japan,
Take a deep breath.
in France, that almost 68% are in PCIs are being done by the radial approach. 68%.
Well, for STEMI the number is even higher.
Higher. Yep.
Yeah.
We're not doing LV. Leave it.
You leave it.
Yeah.
Probably need a size bigger.
Yeah. Well, I mean, we are thinking about the LV, but many of these cases you don't need the LV. But let's try to do a left injection, and then we go to the right. Okay, what guide we are going to use? Get everything ready quick.
We have the VL.
Okay, good. No, will be 3.5. Good.
No. Okay, 3.5.
We'll see that now. Yeah, good. 3.5 will be okay. Yeah, the key is same thing, that catheter manipulation is little more by radial. There is no question on that point. Yeah, good. Keep holding, Sine.
No. Lung shield. Go, inject.
The circ which had 2 stents is fine. So we are going to go to a.
No. Take just a cream.
Okay.
Okay.
Let's do one. Good. Okay, epicranial. Yeah, as Anu pointed out, one of the most important region is the patient restless, moving arm, and so the sedation and nitroglycerin. IV nitro, if some happens, I have seen cases where you cannot advance it, you put IV nitro, and then patient is sleeping, and everything is working very well.
So, I mean, how did this the Tiger catheter compare with the regular Judkins gel?
No, I think this is quite good. Require little manipulation. Only problem is for the right coronary artery, it's difficult. You can go into the ventricle, you can do the left, but right sometimes required.
See how it faces up the hook.
Yeah.
So if it is a downward facing and all that, RCA could be a problem with this catheter.
But many people use the multi-purpose even. The multi-purpose coming back. They use the multi-purpose. Good.
Okay, good.
But
Anu, are you using either for the left or the right? Are you using any different views than standard?
No.
Exactly.
Same standard views.
Excellent.
So now, since we knew we had some tortuosity at the level of the subclavian, I think it's best you do the exchange.
And I think nothing
Now,
wrong in that exchange. Yes, we rather encourage doing exchange. In this case, did we give angiomax here?
Yeah, ACT is 300. Yeah.
Anu,
Now, other point also by using Terumo, yes, Terumo is a very good wire to go through all these curves and tortuosities in the subclavian. You got to be very careful. You could dissect the vessel starting right from the brachial radial subclavian with these wires.
And same thing with this Tiger and Jackie, that quite a big work being done by the Terumo has kind of committed to come up with the new technique, devices, and so. And they actually have the special even guiding catheters for the PCI. But I think that the most of the time, the guiding catheter we still go with the Judkins, but little different modification. Maybe sometimes a smaller size. But for the diagnostic, this Tiger and Jackie catheters are working very well. So one shot, one catheter, you are able to make the full diagnosis and right away. So don't prevent multiple exchanges. and clearly that translates, in my opinion, to a lower spasm.
So, I mean, there is a unusual question, which may be either because your imaging quality is either very good or not so good, but the question specifically is, what imaging system are they using?
Ours is it's a Philips,
Flat
and
panel.
yeah, flat panel, and very good, and then also has the stent boost in it. Now see that very nicely, the catheter is sitting. Clearly that
A lot more guiding catheter support.
yes, and therefore sometimes you need to. This is VL.
Yeah, VL35.
Yeah,
Math.
VL35. Yeah.
Big column of
Yep.
air.
Basically, again, have to be very careful in terms of that there is no air column. Many times when catheters exchange takes place, that we need to be very careful. Good. Let's see it now. We just take a guiding picture. And you can see that this is the LAD diagonal bifurcation will be our issue. Good. I've given the nitro. Always give a nitro and take a picture.
You have?
Yeah.
Now the question always comes in this mid calcific LAD, since it's a short area, do we just, we are going to do rotational
No, this
atherectomy?
one need a, yeah, clearly in my opinion,
fine cross.
and this question we always have.
Fine cross.
So we can go direct wire, no? Let's try. Yeah. We'll try the direct wire in this particular case. Now the question comes that what you do IVUS and so in our lab. Once you see on the both walls calcium. Now, yes, you can get away with the other technique with the high pressure and so on, but I can tell you will be more struggle. So if you are set up, use a 1.5 bar, 1.75 bar, right, and that will decrease your overall struggle, stent delivery, and dilatation.
So, I mean,
Post-dilatation.
no issue with the using IVUS through transradial?
Yeah, no, same thing, no issue with the rotablation, no issue
We
with
have
IVUS.
done IVUS, we have done FFR, we have done the lipid scan, everything via the radial.
Need a clip. Yeah,
Yeah.
the clip there. Yeah, clip. Now clearly with the rotablation, while we regular wire 014, we try to go with without the attachment and so with the torquer. So, but rota, I always say you're using a de novo without exchange, then use the clip. Clip makes it 1-to-1 torque. Because as such, the rota wire is the very difficult wire to manipulate. Hopefully, ever we'll see some changes. But pending any changes in the rota wire, we had to use the best strategy what we have, and it's a rota floppy by every means. That all cases are done with the rota floppy. Rare cases will go with the rota extra support when there is the issue of the support, maybe in the ostial lesion like RCA or very distal lesion into the AV continuation of the right or left.
So I think the radial board, that is the one homemade board. If you see here, we have a nice working space.
Yep. And that's a very
Should be
important
excellent.
point. That key, that once you commit the radial, you have to have this basic things done. Because once you don't have this, you'll have a higher failure rate. And you'll have a very low threshold, get frustrated, your guide is coming out, the catheter hanging on the floor, wire is there, so that you basically say, well, forget it. I'm just going with the femoral. But very simple, so that you need to be very, make the program in the radial, and I'll come back to that point in last our 2-3 slides. Where's the yeah.
So same, you place your rotablator console on this shelf.
Yep.
The
Anu,
clip, yes.
would you feel that the real gold standard for decreasing bleeding is a combination of transradial plus bivalirudin?
Well, I can answer you that question based on the acuity. That in the radial, that it was not that it decreased significantly in the radial, because the same. I would say it's the bivalirudin. The both are independent, but I yet to see a data that they are synergistic. That's the only thing I can say. I felt that based on the acuity sub-study, which came out in Euro intervention, that we'll have it that patients who are radial And now we are waiting for the horizons, the data from the same radial, so that if that gives us answer, that combination of angiomax, bivalent and radial had a further decreased vascular complication bleeding is a different story. But so far, we have the data from acuity. The data from the acuity that radial, that it was not any additional beyond what was achieved by the bivalent. The independent means they both were predictor, but not synergistic. And that's the slide I have shown it.
A lot more moving of the guiding catheter in and out of the left main with the transradial, or
no. I think just in this case it just happened. You see that the tip of the wire is in the septal. We are trying to take it out from the septum, so that is why I think.
So what size burr is this?
So it's a 175 burr. So
175, you have no problem at all with the 6 French?
No.
6 French and radial.
Go. So we do our 3 steps again. You take the tension by moving this knob, Y connector backward forward, and go on fluoro.
I think we pull back the burr a little bit. Which balloon we have selected?
We don't have a. Good. And just do the dyna. No movement. I'm going to adjust the guide a little bit.
Yes. Excellent point.
Yeah. And then just start. So this is where the highest chunk of calcium is. Same slow pecking motion. It's about 150 RPM. When they say 20, I stop.
Actually, there is a small disease proximally also. In the proximal LAD, about 50%. So we need to be very careful that we are done the rotablation coming back into that. It's a small, mild lesion, but we'll try to do a polishing that area also.
Now I have to advance the guide and hold it, because every time the burr is reaching the lesion, see there it's trying to come back. So I'm advancing the guide with my left hand and advancing the burr with my right hand.
Still have not gone through the tightest.
So far hemodynamically maintaining good.
Excellent.
Anytime the blood pressure will go down to in double digits, my nurse will automatically give the neosynephrine to keep it in triple digits.
So the important point here is that it's a short lesion but heavily calcified, slow pecking moment. So will be few millimeters at a time.
And the question always people ask that what is our threshold to downgrade the burr size if it is not a 1 point, you're on floor.
That was exactly my next question.
The thumb rule basically is unless patient is having a significant ST wave changes, that we do at least 8 or sometimes 10. 8 to 10 passage. If you cannot go through, then you go to 1.5. You downgrade the burr from 1.75 to 1.5, 1.5 to 1.25.
Samin, that appears quite a bit more aggressive than what people would tend to do. They would probably start downsizing after the 3rd or the 4th passage.
Well, only problem is that what we learned that we are not going to go with a bigger burr to begin with, and therefore some people they will do it after 5. That you have done the 20-second ablation, so they are 1.5 minutes, and if you're still having a problem, then you just go down.
So what a rotational atherectomy, as you know, is based on, you have diamond chips at the tip, and I think what David Oth had shown that after 3 minutes, those diamond chips actually lose their property of ablation. So you can also pay attention to the time of ablation that we are doing. So far we are done, now we are close to 2 minutes of ablation.
So at what point would you make a decision to alter the speed?
That's a good point, which is about now 145 to 150, and with a 1.75 burr, I definitely would not go beyond 160, because clearly that is associated with a higher spasm, higher slow flow, and so that we can turn it up to go to about 160
I can tell you one of the most important teaching point, Anu, is exactly what you're doing at the moment, pausing. I think that is so critical to
because
perform.
this is that I think crossroad where you have to pause and think, do I downgrade or do I increase the speed and continue?
I would downgrade, but you are the expert.
Now going up with the speed, since it's a bigger burr, I think like Dr. Sharma mentioned, we have to be very cautious. If this was a smaller burr, we are talking about 1.5, we would have no problem to go up to 170.
Good. All right,
But
let's
I think
try
we
one
have
more
gone up
to 160.
Yeah.
Yeah. And then, yeah, no, let's do one with 160. Good.
Get the 1.5 burr ready.
Yeah.
Downgrade.
Good.
Moving a little forward, right? Yeah.
Yeah. Okay, you know what, also, what I do sometimes is that let's just take a picture.
Right.
And just understand where things are. If you see the angiographically not looking good, then maybe it's a better to just go and downgrade. Just take a quick picture. It will be a little diluted one. Yeah.
Well, looks like you need to go back to the 1.5.
Yeah. The last one you do, and then we go.
You mentioned in your presentation that
Yeah. Yeah, I think it's. What do you want to do?
I bet you if we had an IVUS that would show severe one quadrant calcification, which is hanging the.
Yeah.
Samin, you had mentioned in your presentation that 80 cases looks to be about right. Have you done 80 transradial interventions?
Yeah. I mean, now as a combined our cath lab, yeah, sure. We actually have probably over 200 now, because many of our, the one actually personally, I would say personally over the period of time, yes, that every year like 50, 60 sporadic, but we are going to come out now. Yeah,
Well, that's because of the volume you people have in your cath lab. For most other people doing 100 cases, transradial would take them a long time. However, I think the key is that they should have a consecutive series of cases which they should do.
That's the key. That I do not have. I can just tell you clearly that we do, we are low threshold of doing the radial now, but we are far from making it a uniform in every case. But that's okay also. I mean, I think it's that understand, as long as you provide the service, you are good at it. It doesn't have to be that every case has to become radial, and you make your own decision.
I am sure your fellows are benefiting greatly, because this becomes a very useful part of coming out as a completely trained interventionalist.
Actually, that is
I have two fellows here, Vinod Patel on my left and I have Usman Babar. Actually, if you talk, most of the diagnostic, and when we know likely normal, some of this normal, these fellows are doing independently radial. They probably have done a lot of normal radial caths by now. Usman, how many?
Yep.
So far, yeah, independently they are doing radial. And you, Vinod?
Anu, for whatever reason, either from spasm or some other anatomical reasons, if you had not gone right radial, you are certain you would have gone left before transfemoral?
I don't know what Anu will answer, but I can tell you
Not me.
that will be the last resort, go to the left. Just to say the way our systems are, the left access, radial, brachial, you name it, just very difficult. Now, in some patients, it's okay, like thin patient, this kind of patient, okay, you puncture left, bring the hand crossover. But many of them with a good size little belly, you cannot bring their hand up, and it's you end up in breaking your backbone and all this complexity.
I personally would not want to do left radial, though many people prefer doing.
So you would do it only for vein grafts or some specific anatomical
or
reason.
lima and so
lima, those kind of situations when we are really pushed to.
Samin, completely you think there is no reason whatsoever to be using a brachial route now?
Yeah, brachial, I think only if you have just the radial became occluded or now spasm,
Or
those
same a bypass case where radial have been used and you have no radial access, then you have to go brachial. The issue with the brachial access is very easy, but subsequent hold is a problem. No matter how good you are in holding, you end up with the brachial hematoma.
Anu, how much is your conversion rate from radial to femoral, the failure rate?
Oh,
I would say about 10%. That once the cases we decided by radial.
I thought it would be lower, but
no, it's about 10% still. Actually, I had two patients.
I think biggest problem are at the subclavian tortuosity.
Yeah.
Calcified subclavian tortuosity, elderly patients is a problem.
Still a very humbling procedure.
Yes, I mean clearly what happened.
This absence of this rota glide.
That spasm, you know what happened is that they just developed spasm. This patient wanted radial just last Friday. We started radial, came out very good, and now ready to do the intervention. That during that time developed severe spasm. We gave all tons of nitro and so forth. Even then, and
okay, good.
Yeah, and even then, that therefore for the diagnostic was done by radial, but for intervention we had to switch to femoral.
Samin, do you have a formal way how you are trying to ascertain patient satisfaction between radial and femorals?
We actually, I think this is something which will assign one of our NPs making this kind of a, once you go dynaglide, I'll pull. Because see the wire has gone very distal. So you go on dynaglide, make the dynaglide right now. Yeah, now I'll pull the wire, so sometimes it's very difficult.
Anu, 150 or 140?
Yeah. We are at 150.
Okay.
Yes, that I think that will be a good project. That
now, what you expect is that this burr will fly.
Yeah, and it does.
Yeah.
And that's
this
exactly
is
what it
usually
did.
the process. Okay.
The now question will come, which is a very important one. That do you go with a 1.75 versus what? But
no, I
usually
think,
no.
We have done the majority of the ablation with 175. It was just the last 1 millimeter.
I'm going to make your decision easy. What if I told you have less than 10 minutes?
Very good.
Yeah. That's it.
The wire is still in the coming out of the apex. Okay, give me the run through quickly.
So you're going to exchange the wire here?
No. No. We leave the wire there. This is so difficult of this.
Go.
No.
Keep it on one side. Remove this part. Yeah, therefore what we'll do is...
take a picture, very important. You take a picture and see how the vessel looks. So once you have done the rotational atherectomy, since it's a 300 wire, what you do is clean it, make 3 loops, and keep it away from you.
And this is, no, leave the bar there in case we need a 1.75. But
no,
look at this.
Looks good.
Looking very good.
Very good. Yeah. So what we'll do otherwise also, that you have bigger bar, you put a wire into the side and then you dilate. And if you still cannot crack
What are you planning to do for the diagonal?
Yep.
Could be just a balloon.
The balloon. No, because it's a 2.5 millimeter vessel, 2.25 to 2.5. So the goal here would be a one stent approach. So that clearly that your approach has to be very clear to begin with.
I mean, one could even talk about leaving the diagonal
exactly.
alone.
I think that's not a bad idea.
Yeah.
Leave it alone.
Go to scene minor.
I mean, really, the ostium is not involved. It looks.
Yeah,
to
no,
be
it is actually plus. Here.
Yeah, you're right. Okay.
It's a quiet disease actually.
No, I take it back.
Yeah.
Then you have to give me the field net.
Right.
But it's amazing how nice the LAD is.
LAD is fantastic.
I don't think we can attribute that to the transradial though.
Yeah. Well, maybe it's a little angle of the rotabar.
I bet you Fajade and Patel and Sunil Rao are delighted at this result.
Yeah. No. The key is that maybe that is what we say many times. You have bigger luminal gain than your burr, and usually And I think usually don't leave 3 wires. Take the rotor wire out because a lot of crisscrossing otherwise. Yeah, Floro. Yeah. That what happens is that sometimes they are cutting the rota occurs that wire bias that cut on the special side of the vessel so that it is more favorable in terms of the luminal gain. Now this actually ideally in the past these kind of cases even that diagonal we would have been doing a rotablation because of the calcium, but we learn nowadays that as long as this remains okay after osteal dilatation and even with moderate lesion left, residual 50%, 60%, that's okay, rather than going with the more, I would say, aggressive strategy. Keep that on the top.
Here.
Okay. Also get a high pressure balloon. Or you want to get a track?
Yeah.
Let's get a track 2.520.
There's a question coming possibly from Vietnam. Should we use drug-eluting stents for diagonal branch? I think we've already answered that. We may even go just with the balloon strategy here.
That's it. Yes. But you are right. If you plan to do 2 stent strategy, then it's yes. And this is the type of case which I would say that where the question which I mentioned last time is not one or whether should be 1 stent or 2 stent. No. It should be that you need to decide which case you are going to need 2 stent. This kind of case, I would say 95, 98% of time you will be able to come out with a 1 stent strategy.
Anu, what do you have there? That's a balloon?
3 or 20.
Yeah, that was a 3 or 20.
So that's your 8 atmosphere test.
Yeah. And opened up very nicely.
Yeah.
Okay.
And what happens once it has opened, we go and crack the
NC
lesion
void.
almost up to 14 atmospheres. So we know we have a good
Overlap.
expansion. On here.
Little back.
Okay.
When one could have argued the way the result looked, you could have stented
Direct
immediately after that.
Yeah,
too.
go.
Well, I mean, that's of one point, but I can tell you that time to time you'll have the cases that even after rota that you are not expanded. And here, this is the 12 atmosphere, fully expansion of the stent at this time. We have the balloon ready.
We don't need to do the area proximal to
the proximal area actually, the LED is good. So this we are dilated, we pull back. And then we'll use a 3028 stent in the end, but let's do the diagonal. You take
3.0 or 3.5?
I think 3.5.
Okay.
Huh?
Yeah, I might.
We can take another picture with
we'll
some
do that.
nitro. Let's.
Yeah.
Okay, 3 or 28 may be a good idea.
Yeah. Yeah. What I have seen with the Xience that it's okay to go to the 1-to-1 vessel size, and if you need to then dilate later, you can go with the higher balloon.
Right.
Yeah, guidance.
So Anu, give me a sense of this. You look pretty relaxed there. Is that how you feel really? You've done enough transradial that it doesn't, bring in another thing to struggle with?
I don't know.
I bet you it happens with time. It's the comfort level increases. But I'm almost certain that the reason the procedure is not picking up is because of this hesitation.
Yeah, I think that's a very, very important point. That the fear of unknown, that you are so comfortable with the femoral, you say, why the hell I want to go through this new technique and so forth, and expose yourself. But no, but if you think this one technique is beneficial, I think it's worth putting our time and effort. I'm dilating now.
Anu, 2.5 balloon?
It's a 2.520. It's a new track balloon of Abbott, which they think it's the greatest balloon on the earth, but it's okay.
All right.
Going to your same question, Samir, I still have some reluctance in doing all cases radial only because I'm still not clear that radiation exposure to the operator is lower than femoral.
Well, considering how much cases you do, I think that's a very valid
That's a very
concern.
big reluctance from my point.
Do you use a skirt for the radiation?
Yeah,
prevention
everything. And always I make sure either a fellow or the radiation shield is in front of me. But when
now
you
as you see that what we are doing for the diagonal is getting a good balloon results, and that basically is you get 1-to-1 balloon, crack the lesion, and then whatever 10, 12, 14 atmosphere, then go down to half. Leave it for about 30, 60 seconds, so that now the cracks of the plaque is now basically being tacked up.
3 or 28?
3-0.
Well, I used to often
this will be
use this
dissected
technique in the era before stents and predict that one could get a stent-like result.
Yeah.
I think the key is going to be
extend the
that mid portion there because that's where you had the real tight waist and there is some calcification, how that comes out.
Yeah. Let's take a picture, then we decide what to
Okay,
do.
go up here.
Yeah. Okay.
Low
You're going
pressure,
once
low
exactly
pressure.
at that low pressure again. Try to tack up those intimal flaps of the side branch. And as far as the platelet inhibition is concerned, you can always, in the complex cases, you can give 2B3 if necessary, but this patient has been on prasugrel, has a very high inhibition of 77%, so that's okay.
Anu, the way of using bivalirudin remains exactly the same, no
Yes,
difference?
same. That means we give it through the radial sheath.
All right. Just for the except the ostium, the rest is looking quite all right.
You want to just do a little cut? Yeah. 2.5 for 6
No, cut will dissect it. I think leave it alone.
Huh?
Leave it.
No, stand across here. But question is, ostial diagonal, do you want to do? I would say just get a 2.56 cutting balloon. Come quickly, just few seconds. It's already a little dissected right now.
It'll make it worse.
Yeah, no. And then put a stent across. Now then question comes, if you have a dissection, it's a 2.5 millimeter vessel, will come out into that bailout conventional stent approach. But this case, in my opinion, will be good enough without putting a stent in the side branch. There will be just rest of the diagonal has behaved very well, except the ostium. Okay.
No, that's okay. You're holding the one.
Well, one of the approaches would be to take care of the LAD and then decide.
Yeah. Of the diagonal, yes.
I think if you have dissection, then
Exactly right.
Yeah, you'll have to take care of the diag first.
So what stent are you planning to use here?
No, right now we are just going with the ostial cutting balloon if we can get through.
Okay.
Yeah,
So that's the
always the issue.
256.
Even 2.56 after rotablation and so will not go.
So you didn't listen to Anu where she was a little concerned that that would only dissect?
Well, I mean, something need to be done for that ostial diagonal because we know that once you leave that kind, and one approach is that you don't do anything. That's one. Or secondly, if you have done it, yeah, good.
Anu, this was not a straightforward maneuver, and
Yeah,
no
so
problem with the guide really. So
Yeah. What I did, you leave the guide. Same thing. I think getting the guide into the vessel only if you want to see something. Otherwise, keep it away. I just moved the wire because if it was some crisscross, and then get the balloon back, and then you go in. But every time when you go in, you just go as you're with a little pushing technique. But you have to be careful. You cannot be going very aggressively, then everything will come out.
Yeah, good.
Yeah.
Yeah, good. And now also as you saw that we were not completely across with the cutting balloon into the diagonal, but as long as nose is there, so that you open it and then you gradually will go in.
Okay, down.
That's okay. Let's take a picture. And if it's okay, we put a stent. Want to go once again? Try
No.
once again.
No,
Okay.
leave it.
Good. All right. Therefore, maybe the tad better, but not clearly has not created any dissection. But at least the ostium we have been able to open slightly. There is a slight dissection at the ostium which we know, and then now we will decide whether later on do we go through the stent struts and kiss it, or if results are good, then we are okay.
323. Yeah.
23?
Oh no, 28.
Yeah. Yeah, 3 or 28. Okay, let's go. I know we are reaching to the last couple of minutes. We should be all good, and if this looks good, then we are done. And I'll just have three our end slides, actually 2 of them, and just the wrap up of the radial, and we'll continue more discussion about the radials in the future, and we'll follow some of the data. Actually, the major presentation of the randomized trial will be in the ACC, and we'll follow through radial and femoral in a large number of cases from the randomized trial by Yusuf and Samir Mehta from Ontario. Ask deep breath.
Take a deep breath, sir.
3-0 or 3-5?
3-0.
3028.
So this is getting stuck at that calcified
That will be okay.
little plaque which was
Yes.
there probably.
Yes.
Little more distal, is it?
Yep, few more.
So now I'm going to get the guide in. Get your wire
That
position.
looks to be good enough there.
No, I think a
1
couple of
millimeter
millimeters
Okay.
inside. Okay. Do we show some dye?
Yeah, good. I think we are okay. You want
No,
to take
no,
a
no.
picture?
I think we still need few millimeter down.
Okay. Take a deep breath. And that is a question actually one of the, we were asked last time that why to give sedation and so. But clearly you are light sedation so that when you need the patient, you can wake the patient up, which we call they are in the twilight lala land. It's good so that they not moving and that many of the time we do discuss while case is going on if patient is very vigilant.
Well, I'm
They get
sure-
very nervous.
I'm sure some people could argue that we need to do even a little more sedation for
Yeah.
transfemoral also.
Yep.
Take a picture. I think, do we get a guideline now? Okay. Good?
Yeah. Which is fine. You want to, if you can get one more
No,
try.
it's not. This is
Yeah.
just movement of the wire. Take this out.
One more try before we deploy it.
Looks
It's
good.
just
If
not
we can
taking
get
a deep
2
breath.
more millimeter,
Well, then deep throat the guiding catheter.
that's
and,
one. You have to put the guide a little bit more in here.
It's not. It's reached. It's a tall guy. So we are no.
I
no
bet
more.
you if you had that second wire down the.
Yeah.
See that guide is making
That's
very
good.
fancy.
Now go. It'll be okay.
I think okay. We just
Okay.
give up.
Good.
Connect it. and-
All right. If need to be, we can put a short stand later on if at the distal edge. Okay.
So I think 23 maybe would have been okay.
Ready?
Yeah. Go.
Okay. Same 12 atmosphere. Will not go beyond 12. Just 12 atmosphere. Cine.
Go up again.
Okay.
Good. Down.
Now we have that high pressure balloon. Keep that ready. Because I don't think this vessel is more. Actually, we can use a 3.25.
No, it looks okay. Leave it.
Yeah, and if it looks good because we have done the rota, we are dilated with the balloon. So if it looks good, we don't need to post dilate.
Samin, my recommendation here would be a quick shot. If things are good, we should finish the transmission here.
Absolutely.
I think the intent was to show them the transradial.
Yeah.
The rest we have demonstrated, and I have no doubt in your ability that you will get an absolutely perfect result both for the LAD and the diagonal.
1 second. Nitro, good. Go. Okay. Need a little distal work. That's the only one left. Diagonal is okay.
Well, distal little.
Yeah.
I-
Yeah, we might end
so
up in
sure
putting a
maybe.
small stand there.
Yeah,
But
either.
overall, just to demonstration of this complex bifurcation case and
Get us that balloon.
Samin, what would you do for the diagonal though, the ostium?
yeah, I would leave it. If it remains at TIMI 3 flow, basically we will not do anything for that.
So you plan to put in a short stent distal?
Distally. Yeah, I think that definitely we need to do a little balloon and put a short stand because that real final area we are not being able to cover it completely. Right, Anu? What's your plan?
Yeah, first I'm going to do a balloon of the distal portion of the LED. Like you see, I took out the diagonal wire, and that wire I put it in the LED. Now I'm going to go on the fielder because that was a fielder wire with the balloon. Do a long inflation. If it does not, 3020. We leave it there. If it does not look good, then I would put 3012 stent at the distal edge of the LED stent.
Right. And if that is, we can come back to just the finishing slides because that's basically was a very beautiful demonstration of the commitment and able to do this complex case. So just a few points, and I'll take only 2 minutes. That is, you want to do a radial program. Very simple. Just as, don't think that, okay, I want to just do it radial. You need to know the subject. So they read the literature, attend the course if possible. Very important, because you have to train people around you. It's not you, it's people around you has to be buy into this radial process, because femoral has been so simple and so easy in the past. So very, very important, because and also the whole thing changes, which we showed. The patient can walk in, you don't have to even patient undress, just they put the sleeves up. Where do you use? Your beginning cases should be your young male with a large the radial artery, so that the no success rate will be higher. In the beginning, don't do it in the small body surface area, patients, elderly female, and so, which we call LOL, little old ladies. Don't try that in the beginning. You will be disappointed. And clearly, that never push. Patient starts having chest pain, that means there is a trouble. Don't think that radial, you have to keep it. If you have a problem, you just stop. Change it to the femoral. Nothing wrong in that. You can convert. It's not a religion. Wait until you feel more comfortable for the cabbage patients, and of course know your limitation. The indications, as we said, low diagnostic, patient's request, PVD, morbid obesity, hematological abnormality, high INR. Do not if you need to let them come on the Coumadin INR of 2.5, warfarin 2.8 or 3.0, radial puncture, no problem. Thrombocytopenia, no problem. Physician preference, and that is very important to me. The indication of radial is, now it is the right thing to do in all. The TRI wave is in USA. If you are not doing it, you may be considered as a mature or an old-fashioned catheterizer. So you need to be on the bandwagon of the radial. And this actually, towards that, a very interesting paper in JACC Intervention 2 months ago, that basically took the results of the first international transradial practice survey. Now you can see in the US, basically that they stay the same or increase. That USA, they have the highest in the entire world, various countries and so. They had the highest response by the USA physicians that their radial intervention will go up. That clearly, that exactly the highlight was that this is what is going to happen, and we all had to get comfortable. Whether you change it 100% or change it your 50-60% remains to you, but have to be comfortable with this technique, and so that the alternate approach can be given to the patient, and you're no longer amateur or feel isolated. So basically, just to very simple, commit yourself and believe in the radial technique. Have patience, overcome frustrations in initial cases, select your good ones, and of course you need a good guide support. Very simple. You are start doing a PCI, your guide is hanging, flying all the time. During PCI like this case, you'll have a trouble. You have to have a guide sitting. If require exchange and get an appropriate guide, go for it at that time, because otherwise you'll have a trouble few minutes later.
So, I mean, I've always believed that PCI is equal to guiding catheter, and that's even more true with the radial. Anu, you wanted to say something?
We just finished a balloon dilatation of the distal edge, and it looks very good. I think we will not need another stent.
Beautiful.
Well, that looks outstanding there. Yeah. Anu, your final thoughts, give us a summary of what people should have learned from this case.
Yeah, I think important other than what Dr. Sharma's tips are, make yourself comfortable. Don't think this will be a slam dunk case, that's whatever you have. So make sure that when you know that you're going to start radial, not yourself, whoever your associates know what the basics are, and make yourself comfortable, so that when you're doing the process, like we have shown, how calm, cool, so that if you are comfortable, then you know no matter what happens through the procedure, you will be able to overcome it, and if any complication happens. And your lab people also need to be trained how things, if at all there's a complication that you need a balloon pump support, that they are all ready to do it, quick femoral access to be done. The last thing I think I have to add is in the radial, since we don't have, since it's just coming into practice, we don't have a good radial stabilizer. So my fellow, actually Vinod Patel, he is the guy who does a lot of patents. So there will be soon Kini Patel radial stabilizer, which we have applied for patent, which may be soon in the market.
That is wonderful, and I hope it gets approved. Samin, keeping your theme that this should be tried for every case, are you willing to commit yourself to doing these over the next few cases live?
Absolutely, yes. Absolutely. I may get a little backlash by my staff later, but yes. No, but I think that is what we need to do. We need to take the barrier out and basically just go forward, and that is what we are going to show in our subsequent. And even if we have patients with a high risk with the balloon pump or impella, we'll put from the leg and do the radial interventions.
Samin, this has been outstanding. Congratulations, Anu, for excellent demonstration. And I hope all of you have found this useful. We'll be back with case number 22 on April the 19th. Dr. Sharma has already mentioned it is going to be a transradial intervention, and hopefully this has been useful. Once again, keep following us on Facebook and Twitter.